Blackwell.
My lady, in our third topic of scope, we will cover vulnerability and impact. The inquiry has learned that the impact of COVID-19 was not shared equally. As Peter Matejc of the Joseph Rowntree Foundation expressed it to the inquiry, we may be in the same storm, but we are not in the same boat. Certain groups in society were at greater risk of acquiring COVID-19, of suffering severe illness, of dying from COVID-19, or of suffering long-term symptoms. While society as a whole suffered as a result of the social, economic and cultural consequences of the pandemic and the measures taken in response, the people who suffered most were those who were socially, economically and medically disadvantaged before the pandemic hit. You have already concluded that there were people who were particularly vulnerable, whose position was not considered adequately and speedily enough in the context of the pandemic. You have identified failings and harms which resulted, proposing tools for the future. These tools include a recognition that consideration of impact ought to inform any principled approach by future decision makers as to strategy. In this short opening, we cannot possibly attempt to replicate the spectrum of evidence gathered by the inquiry as to the unequal impact of the pandemic, whether by reason of protected or other characteristics, by demographic or additional factors, beyond brief headlines. The evidence in this module points to impact and inequality being predictable, with the pandemic and measures taken in response compounding existing inequalities across the board. The intersectionality of vulnerabilities further exacerbated this effect. By way of example, people with mental health problems are more likely to experience homelessness, social deprivation, domestic abuse, and substance abuse. The mental health charity Mind's 2021 report on poverty called this a spiral of adversity. You have recognised significant data gaps in all 4 nations which may undermine helpful comparison, including by ethnicity, occupation, religion or disability status. We repeat, because it warrants repetition, there was a lack of comprehensive, equality disaggregated data that led to a general failure by the UK government and devolved administrations to understand who was the most vulnerable to the pandemic and how the government's interventions could be better calibrated. There is evidence that risks were heightened, both as a result of pre-existing structural and societal inequalities and as a result of limitations in the planning and response. Throughout these hearings, we will consider, with the assistance of expert evidence and contributions from core participants, how you might build upon the lessons already identified and changes to systems and structures that have already been put in place to better ensure that those most vulnerable to harm are protected in any future pandemic or whole system crisis. I turn now to set out those vulnerabilities and provide some examples of the evidence that you will hear, turning first to race. Those in ethnic minority groups faced some of the highest mortality risks from COVID-19. You will hear, once again, from Professor Nasru, Professor Emeritus of Sociology at the University of Manchester, and Professor Beccares, Professor of Social Science and Health at King's College London, on the experience of people from ethnic minority communities and how their inequalities were exacerbated by the pandemic. They will say that prior to COVID-19, ethnic inequalities in health were largely ignored and there were no appropriate monitoring systems in place. Factors leading to increased risk of infection and mortality included the greater likelihood of ethnic minority people living in areas and working in jobs that increased their exposure to infection. Furthermore, ethnic inequalities in health, driven by these social and economic inequalities, also increased the vulnerability of ethnic minority people to infection, to the risk of COVID-19 complications, and to mortality. In England, Black and South Asian women and babies were approximately 25% more likely than white women to sustain adverse outcomes in maternal and perinatal health during the pandemic. Rates of major complications from anaesthesia during the period from the 1st of July 2020 to the 31st of March 2021 were higher than pre-pandemic rates for all women from ethnic minority groups compared to white women, and especially for women in the Black ethnic group. You will also hear about increased inequalities in palliative care, with ethnic minority patients being referred later by about 4 days to palliative care compared to white patients. Policies around visiting restrictions for family members and lack of professional interpreting services in palliative care, as well as restrictions around access to the bodies of loved ones after death, had an adverse impact on ethnic and religious minority groups. Many services reported that they had been treating ethnic minority groups no differently than any other groups, but a one-size-fits-all approach disregarded the needs and practices of some ethnic minority families. The pandemic significantly impacted social cohesion and community relationships among ethnic minority groups in the UK, with notable variations across individual ethnic groups. While overall neighbourhood-level social cohesion declined during the pandemic, this reduction was particularly pronounced in the most deprived areas among Pakistani, Bangladeshi and Black ethnic groups compared to white populations. Migrants' Rights Consortium have provided evidence of the significant mental health challenges faced by migrant communities during the pandemic. Unfamiliar social structures, financial insecurity, travel restrictions, pre-existing conditions and trauma arising from distressing circumstances which had led them to being in the UK were prevalent, and those within migrant communities encountered barriers in accessing mental health support. In the post-pandemic period to May 2023, mental health symptoms among ethnic minority groups remained higher than pre-pandemic levels. The evidence review confirms that the different levels of poor mental health were persisting and, in some cases, becoming more pronounced. Professors Nasra and Bekarez raised the issue of vaccine uptake in their report, which the inquiry has already covered in Module 4. It is perhaps just worth reflecting that there were differences in uptake levels across sectors of the community. They explained that the fact that ethnic minority people were not engaged in trials was one of the factors which led to greater hesitancy in being vaccinated, others being a lack of trust in the government, in the pharmaceutical industry, and in public health. Unequal treatment by the police and law enforcement agencies towards ethnic minority people was exacerbated during the pandemic. Pre-pandemic figures showed that they were overrepresented in many stages through the criminal justice system, including in relation to stop and search, arrests, custodial sentencing, and within the prison population. We shall examine how unequal policing practices during the pandemic included disproportionate use of fixed penalty notices, increased stop and search activities, and racialised enforcement. These practices were reported to have created additional psychological trauma and health risks for ethnic minority communities, ultimately contributing to significant higher rates of anxiety and mental health challenges compared to the white population. Now to gender. You will hear impact evidence from Dr. Claire Wenham, Associate Professor of Global Health Policy at London School of Economics, on how the pandemic and the measures put in place by UK governments affected women and men differently. For example, although women were more likely to test positive for COVID-19 in the early stages of the pandemic, partly due to higher exposure through frontline roles in health, social care, retail and education, and greater access to testing, overall infection rates between men and women were relatively similar. Men were at higher risk of severe illness, hospitalisation and death from COVID-19. There were a number of suggestions as to why this might be, ranging from biological factors such as hormone effects or differences in immune response, to higher prevalence of underlying health conditions such as cardiovascular disease, to social effects, including delayed health-seeking behaviour. Women were more likely to experience adverse impacts on mental health and well-being. Women's activity levels, which initially appeared more resilient, took longer to recover, and you will hear that the longer-term decline may be harder to reverse. Pregnancy increased the risk of adverse outcomes of COVID-19 infection. Pregnancy was also a factor likely to result in increased reports of mental distress during the pandemic and in the face of measures introduced to manage risk of infection. One contributor to Every Story Matters said, "During pregnancy, my partner was not allowed to attend any appointments. As a first-time mother, this was unnerving and lonely. This made me feel much more anxious about routine appointments." Existing financial inequalities were reflected in women's experience of work and furlough during the pandemic. Women were more likely to lose their jobs and were more likely to be furloughed, with more women represented in the groups most at risk. You will hear from Dr. Wenham that the pandemic not only worsened existing inequalities, it generated new gender forms of financial disadvantage. Most notably, the collapse of childcare became a unique cause of job loss for mothers. Furlough for caregiving was not formally introduced until late 2020, by which point many mothers had either exited the workforce or reduced their hours. The pandemic sharply intensified existing gender inequalities in unpaid care work within households across the UK. Women disproportionately absorbed the additional care responsibilities brought on by school closures, the suspension of social care services, and increased health needs within families. Caring responsibilities, and in particular primary care for children, was identified as a particular risk factor in adverse mental health and well-being outcomes. But it was not only women, of course, who stepped up to take on additional and burdensome care requirements. One young man told Every Story Matters about his brother with learning disabilities, who, before the pandemic, was cared for by their dad. The young man also has a son with autism and care needs. Their dad died early in the pandemic. As day centres closed, the young man became the full-time carer for his brother and his son. He told the inquiry that managing these changes and the family's grief during the pandemic was stressful. You will also hear that one aspect of the pandemic's impact was an increase in the numbers of people providing care for others who experienced a deterioration in their mental health. Caregivers supporting more than one person had particularly high levels of mental health problems, and those caring for both children and older adults saw their psychological distress increase and mental health decline, with carers doing more intensive hours experiencing a greater decline. Socioeconomic inequality. My lady has already recognised that poor outcomes for COVID-19 infection in deprived areas remained after adjusting for age, sex, religion and ethnicity. Mortality rates for these people were at least double, intensifying grief and trauma disproportionately. Poverty and socioeconomic deprivation was in and of itself an indicator of poorer outcomes during the pandemic. You will hear evidence from Mr. Peter Matejic of the Joseph Rowntree Foundation on the experiences of people living in poverty during COVID-19 and lessons that might be learned to improve their future. He will tell the inquiry that, from the very start of the pandemic, people living with poverty were already at significantly higher risk of poor mental health due to financial stress, insecure housing, stigma, and reduced access to services. A recurring theme in their research was that families already on the edge and navigating challenging circumstances were less able to absorb additional shocks. In essence, they describe COVID-19 adding another layer of inequality. Communities already facing structural disadvantage bore greater emotional burden as a result. Professor Claire Bamborough, Professor of Public Health at Newcastle University, and Professor Sir Michael Marmot, Professor of Epidemiology and Public Health at University College London, from whom you heard in Module 1, are returning to tell the inquiry about their examination of socioeconomic inequalities in some of the key social determinants of health during the pandemic period. In the year 2020-2021, inequalities in housing costs increased, and further increases in debt and rent arrears, the erosion of savings, and severe financial difficulties were most likely to be experienced by those in the most deprived areas across all 4 UK nations. There were protections put in place by the governments which helped mitigate health inequalities. The first national lockdown helped reduce the gap in COVID-19 mortality rates between the most and least deprived areas by 25%. Food insecurity, poverty, and income inequality fell as a result of the universal credit uplift and protective housing policies such as the Everyone In campaign, which helped mitigate COVID-19 related deaths. However, despite the mitigating effects these steps might have had on protecting some of the most vulnerable in society, socioeconomic and health inequalities remained present during the pandemic and impacted substantially on people's experiences, including food insecurity and the impact on mental health and well-being. The return of the COVID-19 restrictions during the winter of 2020-2021 led to a resurgence and, in some cases, intensification of mental health challenges across the population, but financial hardship remained a key driver of poor mental health outcomes. Professor Beckeres has provided a report on the inequalities experienced by LGBTQ+ groups. She will tell you that the UK lacks comprehensive data on COVID-19 infection and mortality outcomes for this group of people. However, although coverage was uneven due to underrepresentation and limited data in many studies, there is evidence that they saw a deepening of pre-existing mental health disparities and experienced particularly adverse impacts. LGBTQ+ people experienced a significant deterioration in health outcomes and healthcare access during the pandemic, compounding pre-existing health inequities. Access to HIV preventative medications was compromised, with widespread misinformation around availability, unclear government messaging regarding permissible travel for accessing such time-critical medication, and inconsistent prescribing practices, which left many without reliable access. A large proportion of LGBTQ+ people, and in particular young and trans people, experienced lockdown in housing environments where family members or flatmates were not supportive of their sexuality and or their gender identity. An online study conducted during the first lockdown on the experiences of 18 to 35-year-olds found that 26% of respondents felt either very uncomfortable or extremely uncomfortable where they were living, and 19% also reported feeling very or completely suffocated due to not being able to express their LGBTQ+ identity at home. The risk to mental and physical safety experienced by LGBTQ+ people living in unsupported housing situations was so high that the charity ACT, a national charity supporting LGBTQ+ people aged 16 to 25 who are facing or experiencing homelessness, advised young people to be cautious about coming out to family due to the risk of homelessness. Refuge, the largest domestic abuse organisation in the UK, reported that during the week commencing the 30th of March 2020, calls to the National Domestic Abuse Helpline increased by an average of 25%. The LGBT Foundation's Domestic Abuse Programme also experienced unprecedented demand for support since lockdown measures were introduced. This included a 38% increase in domestic abuse calls to the helpline and an 820% increase in domestic abuse web page views. Turning now to older people. The vulnerability of older people to infection is well documented. The position of residents in care homes was addressed in Module 6, and we do not seek to repeat that work here. While older people were more vulnerable to infection and more likely to die of COVID-19, they were also more vulnerable to loneliness and isolation. We will hear evidence from Professor James Nasru on the wider experience of later life and COVID-19. His evidence supports the conclusion that the experiences of older people during the pandemic, aside from clinical vulnerability, were particularly difficult. We have already touched upon the impact on older people of digital exclusion and the closure of places of worship. Professor Nasru's conclusions are that while access to healthcare and support during the pandemic period became difficult for everyone, this was more significant for some groups of older people who were reliant on care. Professor Nasru will say, there was an increase in unhealthy behaviours during lockdown among older people. Analysis of data from the English longitudinal study of ageing, which covers those aged 50 or older, shows that 40% of respondents reported spending more time sitting, and about 1/3 reported watching more TV and engaging less in physical activity. However, older people were less likely than younger people to experience a significant decline in their mental health and well-being. The evidence review concludes, older adults aged 50 and above, while still affected, often showed smaller increases in mental distress compared to younger adults, or sometimes they experienced no significant increase beyond pre-pandemic trends. This may be linked to greater stability and access to economic resources or established social networks for some older people and a greater change for younger people. And we will explore this in evidence. Turning to disabled people. The term disability is defined by the Equality Act 2010 as someone with a physical or mental impairment which has a substantial and long-term adverse effect on their ability to carry out normal day-to-day activities. In March 2020, the National Institute for Clinical Excellence, NICE, published a short pamphlet entitled COVID-19 Rapid Guideline, Critical Care in Adults. In the first draft of this document, NICE recommended the use of the clinical frailty scale as a tool for helping to make decisions on whether or not a potential patient should be considered as being eligible for critical care. The scale, which ranged from 1, very fit, to 9, terminally ill and expected to die in less than 6 months, suggested that any individual completely dependent for personal care from whatever cause scored 7. According to the scale, for anyone scoring higher than 5, there was said to be uncertainty around the benefits to them of critical care. This was taken by many as suggesting that those with learning disabilities, stable long-term conditions, or autism should not be considered as eligible for such care. Campaigning groups including MENCAP and Learning Disability England pointed out the inequality inherent in such a statement, and on the 29th of March 2020, NICE reissued its guidance to modify the use of the clinical frailty scale. Despite the rapid revision of the guidelines, the original documents continued to cause considerable disquiet among disabled people and their organisations. These anxieties were not helped when news of the inappropriate use of do not attempt cardiopulmonary resuscitation notices with disabled people began to emerge. MENCAP, for example, reported that in the early months of the pandemic, they heard from their members that these notices had been applied to them without their knowledge. A review of DNA CPR policies carried out by the Care Quality Commission found that there had been unacceptable and inappropriate DNA CPRs being made at the start of the pandemic in relation to disabled, clinically vulnerable, and clinically extremely vulnerable people. My Lady has already recognised the specific risk posed to COVID-19 to people with disabilities, and that many disabled people suffered more severe consequences as a result of steps taken to limit the spread of the virus. Many disabled people lived in fear of infection, lost access to support networks, and felt forgotten. Gaps in the knowledge about direct and indirect impacts of the pandemic on disabled people contributed to the failure across the UK to speedily mitigate those risks and harms. We will consider evidence, including from Professor Shakespeare, Professor of Disability Research at the London School of Hygiene and Tropical Medicine, and Professor Watson, the Chair of Disability Studies and Director of the Centre for Disability Research at the University of Glasgow, who are returning to talk about the overlapping inequalities experienced by disabled people who are often living with underlying medical conditions and in socioeconomic deprivation. During the pandemic, disabled people were more likely than their non-disabled peers to experience higher levels of loneliness, anxiety, and depression, poorer well-being, and their access and communications needs were diminished. The third sector, that is charities and community groups, played a key role throughout the pandemic, and without their contribution, outcomes for disabled people would have been considerably worse than transpired. You will hear that there were regional differences in the way governments worked with the third sector. There is evidence that governments in Scotland, Wales, and Northern Ireland were more likely to work with disabled people's organisations than was the case in England. In Scotland, for example, the Minister for Health and Social Care set up a group and met regularly with the major disability organisations. However, while there was more consultation in the devolved nations, its impact on service development has been questioned. Jim Elder-Woodward of Inclusion Scotland has told the inquiry that, in relation to evidence provided to the Scottish Government by his organisation, there had been little dedicated response outlining how that evidence had been used and what difference it had made, and that another recurring theme was that Inclusion Scotland was increasingly presented with near-final draft policies and plans at meetings, and therefore had only minimal scope to influence key decisions. Similarly, in relation to Northern Ireland, Nuala Toman from Disability Action Northern Ireland has told the inquiry that this organisation was not properly or appropriately consulted during the pandemic. The impact of a lack of consultation with the third sector was that the voices of those they represented were not heard, and so they had to step in and fill the gap left by unclear guidance, such as with British Sign Language. Outcomes for disabled people were better where local authorities and service providers worked closely with the third sector and took account of local needs. You will also hear oral evidence from Pauline Nolan on behalf of the Disabled People's Organisation on the experiences of disabled people and the lessons that may be learned for the next pandemic. In March 2020, the UK government delineated two groups who are perceived to be at elevated risk of increased morbidity or mortality from COVID-19. Those who were described and defined as clinically vulnerable and those as clinically extremely vulnerable. Those defined as clinically vulnerable were considered to be at moderate risk and included people with pre-existing health conditions, pregnant women, those aged over 70, and people with a BMI of greater than 40. Approximately 25% of the UK population were included in this category. The term clinically extremely vulnerable was applied to those with conditions that placed them at high risk of complications or death if infected with COVID-19. This included people with certain types of cancers, those who were immunocompromised or immunosuppressed, solid organ transplant recipients, and people with severe respiratory conditions. The experts will tell you that the 4 UK administrations applied different criteria in defining the category. Initially, the criteria for inclusion on the shielding list in England was exclusively clinical. People were informed by letter, either from their GP, other health provider, or through digital cohorting, when they were included on the list. These groups were amended and changed throughout the course of the pandemic as new information emerged. For example, in autumn 2020, people with Down syndrome were added to the list, and in February 2021, this was extended to include all people with a learning disability. By the summer of 2021, it was estimated that the total number of people defined as clinically extremely vulnerable was 3.7 million in England, 213,000 in Scotland, 138,000 in Wales, and 80,000 in Northern Ireland. You have already recognised that the specific risk for clinically vulnerable people went beyond the immediate threat of infection. Extended shielding, repeated disruption to healthcare access, and prolonged exclusion from everyday activities meant that risk management became a constant feature of daily life. You will hear from Lara Wong on behalf of clinically vulnerable families, who has given evidence before you in previous modules and will explain that existing challenges for those deemed clinically vulnerable were often compounded by pre-existing health conditions, which created new barriers to social connections and disrupted access to sources of emotional support. This group was strongly advised to avoid any social mixing in the community, to work from home, avoid public transport where possible, be particularly stringent in following social distancing guidelines, and to try and stay at home as much as possible. Clinically extremely vulnerable people sometimes reported difficulties in obtaining antiviral drugs after testing positive for COVID-19, and they reported delays in routine care, such as blood tests or cancer screening, leading to worsening of chronic conditions. Professors Shakespeare and Watson will explain how the COVID-19 pandemic and the various lockdowns had a significant impact on the health and well-being of clinically vulnerable people. Rates of antidepressant prescriptions were approximately 50% higher for clinically extremely vulnerable people than those who fell outside of the designated definition. In Module 2, you have recognised the known psychological risks associated with shielding for clinically vulnerable people. The evidence review confirms that shielding or consistently staying at home was associated with an increased risk of elevated depressive symptoms, anxiety, and decreased quality of life. Prolonged or repeated shielding was strongly and consistently linked to poorer mental health and quality of life. Clinically extremely vulnerable people consistently reported poorer mental health and well-being. The evidence on the wider experiences of those who were clinically vulnerable but not clinically extremely vulnerable remains complex, and we will explore gaps in data and the understanding of their experiences with the experts and with Lara Wong. Turning now to homelessness and housing insecurity. You have considered the particular risks associated with socioeconomic disadvantage and have made recommendations in connection with the appreciation in future pandemic planning of all harms, including deprivation. People's housing situations had a profound impact on how they experienced the pandemic. For instance, those in overcrowded houses experienced greater increases in psychological distress. The likelihood of spending the pandemic in poor quality or overcrowded housing was higher for those renting and for those in more deprived areas. Overcrowding rates were especially high for certain ethnicities. Poor housing and housing insecurity was a risk factor for poor mental health outcomes. This was perhaps predictable in any crisis to which a necessary response was an instruction to stay at home. Housing conditions were recognised as a structural driver of poorer mental health, particularly in more deprived areas, and this was disproportionately experienced by socioeconomically disadvantaged and ethnic minority households. In the coming weeks, you will hear evidence on the particular vulnerabilities, risks, and disadvantages experienced by those living with housing insecurity and homelessness during COVID-19, including from Tim Gutteridge of Shelter, Nicola McCrudden from Homeless Connect, Northern Ireland, and Ruth Power from Shelter Cymru. The Everyone In programme was welcomed, but the management and ending of the programme may have had an adverse impact on homeless people while the pandemic continued, and its impact continued to be felt. There were divergent experiences for those who moved from street homelessness to COVID-secure accommodation. The transition from face-to-face to remote contact with support workers was a particular challenge. This was an area where overlapping inequalities were particularly pronounced for those with complex needs, care leavers, people with mental health conditions, people at risk of domestic violence, and migrant people. There were sometimes additional challenges for those key workers running the hostels, charged with the responsibility of managing the influx of people. Shelter told the Housing and Homelessness Roundtable, people were put in budget hotels with no support whatsoever. They didn't know how long they'd be there. People were having terrible mental health crises. In some cases, there were skeleton staff in the hotels, so there were hotel staff dealing with people who wanted to take their own life, having severe reactions because they couldn't obtain drugs or alcohol, and they were completely untrained. You will hear that migrant people experienced the pandemic through a combination of health risk, housing insecurity, and legal uncertainty, with impacts cutting across healthcare, housing, and immigration systems. Many entered the pandemic already facing restricted access to public funds, financial insecurity, and limited access to support. COVID-19 did not create these conditions, but you will hear evidence that it intensified them. There were protections introduced during the pandemic, which you will hear helped mitigate the impacts on migrant people. These included the COVID-19 concession schemes, coronavirus extension concession, and the exceptional assurance concession. These schemes allowed those whose leave to remain would have expired during the pandemic to stay in the UK while pandemic restrictions on travel were in place. However, participants in the Justice System Roundtables said that the absence of clear guidance for these schemes and the restrictions on them made it difficult for immigration law practitioners to advise migrants. In relation to healthcare, fear and uncertainty about entitlement acted as a significant barrier to access. Some migrant individuals delayed or avoided seeking treatment altogether because of concerns about charging, data sharing, or immigration consequences. A representative from the Joint Council for the Welfare of Immigrants in the Justice System Roundtable explained, migrants who were discouraged from accessing healthcare for a long time were cynical at the prospects of accessing it suddenly during COVID-19 pandemic. You will hear from Francesca Humi on behalf of the Migrants' Rights Consortium about the experiences of migrant people and those in the immigration and asylum systems, including as to health risks and the impact on mental health and well-being, and the lessons that may be learned for the next pandemic. Turning to prisons and detention. For people in prison and other places of detention, the pandemic fundamentally altered daily life, with considerable impacts on physical health, mental well-being, case progression, and access to healthcare services. Restrictions introduced to limit the transmission of COVID-19 resulted in unprecedented levels of confinement, isolation, and loss of contact with family. This was compounded by overcrowding, poor conditions, and high levels of vulnerability. Deaths in custody increased over the pandemic period. Beyond an increase in deaths attributed to COVID-19, there was also a concerning spike in self-inflicted deaths, which in the 12 months to December 2021 represented a 17% increase from the previous 12 months. For many prisoners, the most immediate impact was the prolonged time spent locked in cells. The introduction of the Exceptional Regime Management Plan confined most prisoners to their cells for 22 to 23 hours a day, a practice that persisted for months. As His Majesty's Chief Inspector of Prisons described in February 2021, nearly a year after restrictions were introduced in prisons, the most disturbing effect of the restrictions was the decline in prisoners' emotional, psychological, and physical well-being. They described being drained, depleted, lacking in purpose, and sometimes resigned to their situation. Some said they were using unhealthy coping strategies, including self-harm and drugs, whilst others reported using mundane routines to pass the time and cope with their confinement and associated anxieties. You will hear from Andrew Nielsen on behalf of the Howard League for Penal Reform, from Pia Sinner on behalf of the Prison Reform Trust, and from Charlie Taylor on behalf of His Majesty's Inspectorate of Prisons, who will all speak to the direct experiences of those in prisons and other places of detention, the wider inequalities exacerbated by the pandemic, and lessons to be learned. His Majesty's Inspectorate of Prisons noted that many prisons suffered from overcrowding going into the pandemic. Where prisoners continued to share overcrowded cells, often in poorly ventilated spaces, this exacerbated the impact of restrictions and made preventative measures such as social distancing particularly difficult, if not impossible. Prison inspectors also described conditions which were characterised by extreme restrictions, with prisoners often denied access to showers, exercise, or meaningful human contact, and that such impoverished regimes were likely to discourage people who had symptoms from reporting them, posing a significant risk to public health within the prison estate. The ability of healthcare provision evolved over time and between prisons. You will hear that while urgent and emergency care continued, routine services were curtailed, delayed, or suspended, leading to backlogs and longer waiting times. Digital access was welcomed as social visits were suspended, but such access varied across the prison estate. The UK National Preventive Mechanism is an organisation made up of 21 statutory bodies that independently monitor places of detention across the UK. Their representative explained in the Justice System Roundtable, when that access to families worked, it really worked. It really had an impact on people's well-being once they could see their family members and talk to their family members. Comparable impacts were experienced in immigration detention. The uncertainty inherent in immigration detention, combined with pandemic restrictions, intensified anxiety, distress, and feelings of powerlessness, particularly for people with prior experiences of trauma. Participants in the Justice System Roundtable reported that the pandemic had a substantial negative impact on the mental health and well-being of detained migrants. The charity Bail for Immigration Detainees described detainees as being subjected to extended periods of solitary confinement in an effort to reduce the spread of COVID-19 within detention facilities. They reported that some people were confined for over 23 hours each day. They highlighted the lack of clear communication, including as to the expected duration of detainees' confinement, as resulting in increased fear and anxiety. I turn now to domestic abuse. My lady, you have already recognised that significant risks associated with the pandemic, and in particular lockdown, for those at risk of domestic abuse, and have concluded that it should not have taken the reports of traumatic experiences during the first lockdown for the UK government to recognise and act upon these risks. You will hear evidence from experts who will reflect upon the evidence review and the Domestic Abuse and Safeguarding Roundtable report, both of which record the particularly heightened risks associated with domestic abuse, including for people living in rural areas and for those who experienced digital exclusion. It was particularly difficult for those who experienced overlapping inequalities, including as a result of disability, immigration status, language, or other barriers. The DA group, one of Module 10's core participants, is made up of the following groups. Southall Black Sisters, an organisation supporting black, minoritised and migrant women and girls, particularly those fleeing violence. Solace Women's Aid, a service provider for victim survivors of violence against women and girls in the UK, and Latin American Women's Rights Service, supporting migrant women facing intersectional violence and discrimination. They have told the inquiry of how lockdown conditions created the perfect storm for abusers to take further advantage of their victims. Solace Women's Aid told the inquiry's roundtable on domestic abuse and safeguarding, the weaponisation of every facet of restrictions was used as an instrument of pain and suffering by perpetrators. The Latin American Women's Rights Service told the roundtable, one of the different ways through which perpetrators abused victims was data control. If you're providing services only remotely and you don't have credit on your phone or no access to Wi-Fi, or your perpetrator turns this off, victims would be isolated and could not contact statutory services. These difficulties were confirmed by a service user who reported that during lockdown, everything got so much worse. I would usually at least have some breathing space when I went to work, but this was taken away from me when I had to start working from home. My perpetrator would do things like pull the Wi-Fi out of the wall to make it difficult for me to work. They would scream whilst I was having work meetings, and colleagues called the police because they were concerned for my safety. I had a really good job, which I have now lost because of the abuse. You will hear from Gisela Valle speaking on behalf of the 3 organisations that make up the DA group, that these organisations observed that the most significant increase in direct contact from victim survivors occurred when lockdown restrictions were eased. This indicates that many were unable to safely engage during the initial lockdown period and only began to make contact when circumstances allowed even a small window of opportunity. Prior to the pandemic, disabled women were already 3 to 4 times more likely to experience domestic abuse than their non-disabled counterparts. The pandemic presented further opportunities for perpetrators to control them, including restricting access to PPE, testing, and vaccines that would have helped them lower their risk of infection. Perpetrators' coercive control, combined with victim survivors having to balance the health risks of leaving their homes, left disabled and older women even more vulnerable. This was compounded by the fact that their perpetrators were often their carers, and during lockdown would often be their only carers. My lady, you will hear harrowing evidence about an increase in the scale and intensity of physical and sexual abuse during the pandemic. One woman reported to her accident and emergency department that her partner had punched her in the head and tried to strangle her. She said that he had been physically aggressive to her before, but matters had escalated during lockdown as they were quarantining together. Others reported that incidents of marital rape had increased during lockdown. Some victim survivors were forced into pregnancy, while others, unable to access contraception or support, experienced unwanted pregnancies. Substance abuse by perpetrators increased, which, in turn, led to further offending against their partners. A report by Refuge on their National Domestic Abuse Helpline Service for 2020-2021 noted that 19% of women had experienced threats to kill, 10% had weapons used against them, and 16% had been strangled. In addition to what I have just set out, tomorrow, Ms. Rahman King's Counsel will summarise the impactful evidence contained in the roundtable reports which describe the pandemic experiences of the vulnerable. Already, it will be apparent to you, my lady, that there are themes developing, patterns emerging of shared experiences across those in society who entered the pandemic period living with vulnerabilities, of suffering and impact unequal to those better off, of lacking vital access to digital devices which substituted face-to-face services, of a lack of clarity and therefore heightened confusion around rules and regulations imposed by the government, of a deterioration in mental and physical health which continues to this day, of a feeling of being lost and ignored through a lack of data, the presence of which would have better alerted those who needed to know about the detrimental effects that the pandemic and measures imposed were having on their lives. My lady, I'm going to pause again for another break before turning to the final section of the opening, which will deal with bereavement and loss.
Very well, we'll give you a little longer. Save your voice, Ms Blackwell.
Thank you.
I shall return at 3:05.
All rise.
Final leg, Ms Blackwell.
Yes.
Thank you.
My lady, the pandemic and measures in response had a profound and negative impact on the experience of bereavement, increasing feelings of grief, pain, isolation and trauma. This was an outcome that was foreseeable in the event of any pandemic or public emergency. You will hear the moving evidence of 8 individuals who have suffered firsthand from bereavement due to COVID-19 and the impact of these experiences on them and their families, which are still inevitably ongoing. Bereavement due to COVID-19, compared with other types of loss, was complicated by many people being unable to say goodbye and having a lack of contact with the person who died. People experienced profound feelings of anger, sadness, and guilt that they could not be with or comfort their loved ones at the end of their lives. Uncertainty about what happened to their loved one in the final days of their lives had a detrimental impact for many. One contributor to Every Story Matters from Northern Ireland said, "We lost our daddy early in 2021. He was 68, life and soul of the party. It was the most surreal experience, and over 3 years on, I have nightmares. Did he suffer? Was it him in the coffin? Did we cremate the right person?" Amongst a dozen more questions we will never get the answers to. Another contributor to Every Story Matters from Wales said, "The pain and stress we are still going through, I can't live life not knowing how our mum died or knowing how we can find out those answers. It's hell not knowing why she died. It's frustrating and soul-destroying not knowing answers to questions we have, and we can't even grieve properly for her." Many people experienced and still experience ongoing guilt and anxiety as to whether they did everything they could for their loved one at the end of their lives. A contributor to Every Story Matters from Scotland said, "On the day Dad died, I received a phone call in the afternoon to say he was very unwell. At this point, I wanted to come in and be with him, but was told that would not be allowed. I have not really come to terms with this and feel extremely guilty that my brother and I were not there to comfort him in his passing." For some, this led to an exacerbated fear of the virus and that they or other family members might die as a result. One contributor told us, "My mental health became very horrific over this period. Watching my grandfather pass away from COVID made me extremely more anxious regarding catching COVID or another family member catching it. As the restrictions were relaxed to allow brief visits at end of life in controlled circumstances, including wearing PPE or through window visits, bereaved people reported continuing to feel confused, angry, and guilty over the circumstances of their loved one's death. One contributor told us, "I was then not allowed to visit until they felt she was imminently about to die, and to visit once to say goodbye. She was barely conscious and didn't recognise me with all my double mask on. I ended up actually seeing her twice, as she lasted longer than they thought. But basically, she was dying in a room on her own for 3 weeks, with no one she loved there to hold her hand and talk to her. I really struggle with this. And the guilt, even though I had no power to change the rules, I feel a lot of anger that this was allowed to happen. It's not humane and not logical. If I was all masked up, why could I not go in every day?" Many people experienced multiple losses in close succession within the same family. This took a particular toll. One person who suffered such a loss told us, "It's sudden, completely unexpected. If it's caught in hospital, you thought your loved one would be safe, obviously, so it feels like it was completely avoidable. You're angry, it's unjust and surreal, completely surreal. One minute my parents were fine, living their own life, and the next minute, less than a month later, they're both dead." The sense of overwhelm that I felt with all of these factors going on, and I was shielding as well. So I was like, obviously, my parents died from COVID, and I'm terrified of catching anything. I did have thoughts of suicide and self-harm. I'd never in my life experienced thoughts of self-harm. It was incredibly scary. It's apparent that those who were shielding reported particular feelings of fear, guilt, and isolation. Contributors to Every Story Matters who were shielding shared with us that they struggled without social support and physical contact. One of the bereaved impact witnesses, from whom my lady will be hearing, told the inquiry that shielding led to a further deterioration in her mum's health and well-being. Her mother having to shield meant that they lost much of their personal contact. Restrictions on funeral and mourning rituals had a damaging impact for many. It was felt that there was a lack of consistency in the guidance offered and the rules which applied in different parts of the UK and at different times during the pandemic. This was said to cause resentment, confusion, and difficulty for those planning for funerals and mourning. The inquiry has already considered the impact of high-profile failures to observe restrictions in Module 2, considering, amongst other events, the funeral of Bobby Storey in Northern Ireland. COVID Bereaved Families for Justice Northern Ireland told the inquiry that this impacted directly on bereaved people. In Northern Ireland, there was a prominent funeral that broke all the rules. This impacted people about following the rules. You can hold a memorial a year down the line, but that is not the same as the celebration of life. As choices needed to be made within families, this put pressure on relationships at a time of considerable emotional difficulty. A representative from Scottish COVID Bereaved described this to the Round Table on Funerals, Burials and Bereavement Support, confirming that choosing which members were allowed to attend a loved one's funeral caused rifts within the family. The nature of some communities and religions' rituals meant that they were more impacted by restrictions than others. However, evidence from the Round Table on Funerals, Burials and Bereavement indicates that a common theme was the distress caused by the imposition of restrictions. Evidence from bereaved people in Northern Ireland spoke powerfully of the impact of restrictions on the holding of wakes for the dead. We normally have wakes as part of our culture, a time for people to reflect, share memories, bring positives to your life at a time when it is sad. That was completely lacking and missed. The negative impact of bereavement impacted disproportionately on ethnic minority groups. Mind told the Roundtable on Funerals, Burials and Bereavement Support that some communities struggled to understand why they couldn't run funerals as per their cultural norms. COVID Bereaved Families for Justice UK highlighted the role of wakes and the coming together for funerals for African and Caribbean communities. A COVID death is not a normal death. You can't do the important things. For Afro-Caribbean families, the coming together, the wake, is so important. People could not be there. The loss of many aspects of choice in mourning rituals or in the celebration of life robbed many of a sense of closure following the death of a loved one. From the abandonment of family members' prearranged funeral plans to the inability to choose a casket or bury a loved one in their favourite clothes or to have flowers at a service, bereaved people felt they were unable to give their loved ones the send-off that they deserved. This exacerbated feelings of guilt. Where funerals had been pre-planned and paid for, this created a particular sense of injustice, sadness, and anger. A positive reflection is that innovations to allow for remote attendance at burials and funeral services provided a new accessibility which has continued beyond the pandemic period, allowing family and friends to participate in mourning rituals in a manner that previously would have been impossible. Some people told the inquiry that they were grateful that requirements to isolate allowed them time alone with their grief. Allowing services to be viewed online was repeatedly cited by funeral staff as integral to offering an adequate service during the pandemic. Funeral staff have continued offering this service when the pandemic was over, some stating that the streaming of funeral services is brilliant for people who have maybe got family that live out of the UK. That's something that's definitely improved. I'm not sure if it would have happened as quickly without COVID. However, a lack of clarity in the guidance on restrictions, including as applied to different communities and religions, exacerbated the negative impact on their experience of bereavement. A representative from Mind explained that some communities struggled to understand why they couldn't run funerals as per their cultural norms. There was a lack of thought and understanding about how the impact on different cultural ways of bereavement was happening. It led to a white Western understanding of COVID-19 restrictions. Separately, some bereaved people have described an enduring sense of injustice where there was uncertainty as to the circumstances of their loved one's death during the pandemic, and where they felt there was no obvious route for complaint, investigation or accountability while COVID restrictions remained in place. One bereaved person told the inquiry that they only found out the circumstances of their mother's death through the complaints process approximately 1 year later, and the fact that they were not informed at the time and had to complain made them feel angry. Another said that while her husband was in hospital, she was sick with worry and telephoned the hospital to try and get updates as to how he was, but didn't get an answer. The general administrative process of managing a bereavement was made more difficult during the pandemic. After a loved one died, family members had to manage processes like closing bank, utility and other accounts while dealing with their loss. The restrictions in place as a result of the pandemic made this more complicated for many. Witnesses told the inquiry that companies and organisations did not adapt to take into account the circumstances of the pandemic for those who were experiencing loss. There was insufficient support for bereaved people and businesses to navigate what was required, and processes lacked compassion. One contributor to Every Story Matters said, "Banks, building societies, offices, all of them were working from home on limited hours. I spent days on hold. I repeat that only those who suffered a bereavement at the time know how difficult it was. I wanted peace, and all I got was frustration, obstacles, excuses from these companies." Another contributor to Every Story Matters from Wales said that the processes of death administration compounded the impact of their loved one's death upon them. For me, the hard thing was actually picking up the phone and shutting down all the accounts. I almost felt I was complicit in their death, and then I felt their deaths were unnecessary, and I was trying to fight that. But at the same time, I was having to go along with it and shut them down and close them down like they never existed. That was a real personal struggle for me, was to put their lives down where I kind of felt their lives perhaps weren't ready to end. Some felt that there was limited information on how to deal with the administrative aspects of a death during the pandemic, and bereaved people felt that there was insufficient signposting or support. The inquiry has heard that families searched for guidance after a death, that this information was not easily accessible, and that this added to the stress and grief experienced. There was limited opportunity to access different forms of bereavement support during the pandemic for many people. You will hear criticism of delays experienced when people got in contact with support services, and also in relation to the quality and effectiveness of the support that was available. Some found online services helpful. Others thought they were inaccessible, impersonal, and unhelpful. One contributor to Every Story Matters told the inquiry, "When I contacted them, basically, I was just on a waiting list for, I don't know, it must have been about a year. And then I had Zoom sessions with this lady. She was a lovely lady, but I felt that I didn't get that much out of it because I was much further on, and she was more about the basics of grief and that type of thing." We will explore evidence on bereavement support, including from those working within the system who reported a drop-off in referrals in the early part of the pandemic, with assumptions perhaps being made that the service would not be available. Crew's bereavement support, from whom you will hear, told the round table on funerals, burials and bereavement support, there were some real challenges. The rapid shift. Crew's is primarily volunteer delivered and was very local and face-to-face, and moved to virtual using technology that was new to us. Upskilling thousands of volunteers, that can be tricky at the best of times, so at speed, that's harder. You will hear evidence that those working in bereavement services did not feel that they were equipped to support people through a pandemic. The volume of high-pressure work, with many more unexpected deaths than was typical, and many more people dealing with traumatic grief, took its toll on the mental health of those working to support bereaved people, in funeral services, in bereavement support, and beyond. One contributor to Every Story Matters, working in hospice care during the pandemic, told the inquiry, "The impact of dealing with frightened families and patients, coupled with my own worries about my health, led to me experiencing burnout. I'm a counsellor by training, specialising in bereavement and loss. There was an expectation in my role of holding other people's grief and fear, and it came to a point when I could no longer do that, and I started losing my voice." The need for support to meet the financial impact of bereavement during the pandemic was also significant. The National Bereavement Alliance told the inquiry how difficult it was for people to experience grief during a time of more general fear and economic instability. They thought that financial worries people experienced during the pandemic were likely to have intensified people's experiences of bereavement. Some people told the inquiry about the individual financial shocks associated with bereavement and the ongoing adequacy of bereavement support payments which were available. One widow told Every Story Matters, "I'm struggling with losing my husband at 31. I have had huge stress trying to manage financially to maintain my house and take care of my daughter. I'm not entitled to any benefits as my house is owned, and bereavement support only lasts 18 months. Peer support and involvement in supporting others who were bereaved by COVID-19 helped some to process their grief and to feel less alone. Another bereaved widow told us, I found peer support, people who understand because they've been through something similar or even the same situation sometimes. There's that general overall understanding of the emotions, the guilt, the whole thing, and I think that is really important. I think, yes, until you're in it, you don't know about it. However, the impact of bereavement was widespread, and there were secondary and indirect impacts of bereavement as people reported how painful it was to see family members and friends isolated and overwhelmed with grief, while being unable to assist or support or offer support as they ordinarily would. One bereaved grandson told Every Story Matters about the pain of supporting his mother through her loss. My mum has always dealt with mental health issues in one way or another, but this really, really did affect her. Just not actually being able to be there in person for her. Like, if I'm phoning mum and she's constantly there in tears, there's only so much I can say, where, like, a hug can go a long way. This had a wider and, in some cases, detrimental impact on relationships. One contributor told us, we were all a really close family, and for, like, the head of the family not to be there all of a sudden, and for us not to be able to be there, it's changed us as a family. I don't know if for the better, but definitely there's movements with kind of distancing ourselves from each other. You will hear evidence suggesting that a lack of clarity and compassion in communications, including the handling of end-of-life care, had a significant and exacerbating impact on bereaved people. Examples are drawn from interactions with clinicians responsible for end-of-life care and the handling of the belongings of the bereaved after their death, which some believed to involve a diminution of dignity. Social isolation during bereavement and prolonged grief as a result of the pandemic and measures in response have led to mental ill health and poor outcomes for many bereaved people. One contributor told Every Story Matters, usually people come and visit you and you have that community around you. That wasn't there during COVID at all. It was isolated. You felt so isolated. You will hear how this isolation translated into long-term mental health impacts. One contributor told the inquiry, 2 years after being isolated from everyone, I still grieve, and along with other health issues, I now suffer from depression. You have received evidence from Dr. Emily Harrop, a senior research fellow at the Marie Curie Research Centre at Cardiff University, whose work found that although it is generally expected that most bereaved individuals will adequately cope with their grief and slowly readjust to life without the deceased, it is recognised that a significant minority of bereaved individuals will experience more complicated and problematic grieving processes, including the development of prolonged grief disorder. Particular circumstances which were specific to the pandemic increased the prevalence of prolonged grief disorder symptoms in the bereaved. These included factors such as unexpected deaths, feeling unsupported by healthcare professionals immediately following the death, suboptimal communication with families by healthcare providers, being unable to visit, care for and say goodbye to family members as expected, perceived suffering and shock at sudden traumatic deaths, and unanswered questions and doubts. This led to people suffering feelings of powerlessness, guilt, anger, and injustice, finding it hard to grieve and begin to accept the death. Disruption to longer-term support and coping processes further added to the anxiety. Additionally, the place of death was strongly associated with prolonged grief disorder symptoms. Grief outcomes were better when a death occurred in a care home compared to other settings. Although the study did not definitively identify the reasons for this, Dr. Harrop suggests that this may be due to anticipatory grief. That is, death in a care home is often more expected, and less sudden. The experience of grief was affected by demographic factors such as socioeconomic status, ethnicity, and medical conditions. Dr. Harrop told the inquiry that while the study cannot confirm the position, wider literature suggests that such inequities may reflect a poorer quality of service provision in socially disadvantaged areas generally, or different abilities of people to engage with healthcare professionals and the healthcare system. However, they might also relate to the unequal impacts of the pandemic on poorer communities across the UK, potentially affecting community-level mental health and resilience, and in turn a more limited capacity for health grieving and adaptation amongst people living in the worst locations. The impact of bereavement during the pandemic continues to take its toll on many. To take an example of one of the impact witnesses who will share their personal experience with us in week 3, she has suffered from depression with a knock-on effect on her physical health. She has become completely introverted and her memory has been affected. Another impact witness will explain that it is only recently that she has been able to move forward with the aid of a journal. When pandemic restrictions were lifted, some said that this worsened their grief and they found themselves revisiting the trauma of a loved one's death. I touch on their evidence only briefly, my lady, as it is important that they have an opportunity to tell their stories to you themselves. The contributions to Every Story Matters also powerfully underline that for many, grief and its associated mental health impacts continue today. One person told the inquiry, "My partner's death and the circumstances surrounding his death affected my mental health, which spiralled down, and I was diagnosed with depression due to complicated bereavement, as I blamed myself for not looking after him. I still suffer even today, and it is something that will take a long time to get over." A bereaved wife and daughter from Scotland added, "Understand that the impact of not being able to grieve fully, properly, in a supported way, in your family, in your community, and the traumatic impact of that impacts on your physical and emotional well-being going forwards. So it's actually impacting on society in a much longer-term way." Bereaved families told the inquiry about the particular anger they felt over alleged rule-breaking by public figures. They followed the rules, and therefore the allegations of those within the government flouting those rules increased their pain and distress. You have, my lady, already considered the impact of rule-breaking by decision-makers and the huge distress this caused to members of the general public and to bereaved people in particular. The evidence in this module underlines the impact of this behaviour and the publicity surrounding such for those who were bereaved and struggling with guilt over their own compliance with the rules in the face of their continuing grief. One contributor to Every Story Matters said, "Every news bulletin, Partygate revelation, political denial, it all cuts so deeply. It doesn't go away, and to have it constantly referenced everywhere I look and go is an unrelenting reminder of the insulting trauma so many of us have been needlessly put through. All of us suffering this COVID grief have little to no chance of moving on from it." Another said, "The revelations of Tory parties, which took place around the time Mum was dying, have hit me very hard. I can go for a while thinking the pain of losing Mum is lessening, but then Partygate rears its ugly head in a news bulletin and I have to leave the room as I cannot watch. The anger is simmering most of the time." These sentiments are reflected in the written opening statement provided to the inquiry on behalf of COVID Bereaved Families for Justice Cymru in the following way. "And those who followed the rules to their detriment continue to be outraged at the behaviour of those in privileged positions who did not. Bereaved people say they have felt left behind and forgotten as society works to move beyond the pandemic. One bereaved daughter told Every Story Matters, "Pretending that life is the same, it's not. I lost Dad and we all went through the pandemic, and I think the pretense we're back to normal is nonsense, because I definitely feel there's a bit of me that went into hibernation and never fully came out." When looking to the future, some bereaved people highlight the importance of remembrance and commemoration for their loved ones. As one contributor to Every Story Matters said, "Our loved ones didn't have dignity in death, so we must make sure that they have dignity now in remembering. We need to look at ways in which it can be remembered, in a beautiful way for us, for them, and make sure they're not forgotten and what they went through." You may wish to consider, among lessons which may be learned for the future, how loss may be effectively memorialised. We hope that the work of your inquiry and its reports will form a part of that process. Throughout this inquiry, my lady has repeatedly stated that the purpose of these hearings is not only to understand the impact of the pandemic and the measures taken in response, but to learn lessons for the future. And I turn now to deal with those. The inquiry has asked experts and witnesses to consider what lessons might be learned from their experience of the pandemic. Each of the Every Story Matters records and roundtable reports seeks to be forward-looking and so also asks what lessons can and should be learned. In drawing this opening to a close, we reflect on the following cross-cutting themes which are emerging from the impact evidence heard in this and in earlier modules. First, the extent to which the unequal impact of the pandemic or whole systems crisis may be further exacerbated without careful consideration and planning. In Module 2, you recommended that there be a framework to proactively consider those at risk of negative impact and to consider steps in mitigation. In due course, you may consider that the evidence heard in this module is further justification for the preemptive consideration of impact, inequality, and vulnerability in the context of planning and response. We will explore how anticipating inequality will inform those who are charged with the duty of planning for future civil emergencies. Second, while digital expansion is a generally positive story for this pandemic, many were unable to engage. We will consider a proactive approach to innovation which seeks to ensure that no one is inadvertently left behind. This will build on the existing recommendations of the inquiry on digital access, inclusion and exclusion. Third, we will consider how evidence on data gaps in this module relating to particular vulnerable groups provides a strong indication that these gaps must be addressed in order to fully understand the impact of any future civil emergency upon those most affected. This will build on the evidence that my lady has heard in several earlier modules. Fourth, we will consider how evidence on the approach to guidance and communications, on collaboration and co-working, as arising in each of the areas of scope for this module, might be incorporated into strategic planning and preparation for the next pandemic in order that lessons might be learned. This will build on the lessons of Module 2. Fifth, we will consider how lessons might be learned from the experiences of specific groups impacted in this pandemic, and such that might be predictably impacted in the next pandemic, including bereaved people and key workers. Sixth, the impact of COVID-19 is continuing. We will consider how learning might continue to be monitored beyond the pandemic period and beyond the conclusion of this inquiry. Finally, we will explore how the general themes and issues emerging from the impact evidence might build on your earlier recommendations, such that they might be embedded in preparation for and in response to the next pandemic or whole system civil emergency in a way which prepares for a stronger, more resilient recovery. In concluding, my lady, we thank everyone who has supported the work of the inquiry throughout this module. The process of reflection as to how COVID-19 has impacted our lives may have been cathartic for some, but for many, it will have involved reliving and sharing some of the most challenging and painful moments of life and of loss. To everyone who has shared their story, whether by participating in Every Story Matters, engaging in the roundtables, speaking to the inquiry's videographers, preparing a witness statement, or in supporting the work of core participants, we thank you. Every personal story shared with the inquiry informs your understanding of the impact of COVID-19 and the challenges which we will face together in the next inevitable pandemic or whole systems crisis. Tomorrow, Ms. Rahman King's Counsel will introduce the evidence the inquiry has drawn from the roundtables. You will then, during the course of tomorrow's sessions, hear from each of the core participants who wishes to make an opening statement. Many of these core participants have played a role throughout your work on this inquiry. These opening statements, the conclusion of these hearings and of this final module, may for them, as for the inquiry, represent the culmination of many months and years of work to ensure that the impact of COVID-19 on our society is not forgotten, lost or underestimated. Your team is grateful to each of them for their work, focus and dedication during this module and throughout.
Thank you very much indeed, Ms. Blackwell. I'm very grateful too. Very well, I think it's time to adjourn now and we shall resume at 10 a.m. tomorrow.
Thank you, my lady.